Class, and welcome to Chapter 17. This will be on the urinary system. Thanks for being patient as I uploaded this. I lost my voice earlier this week. So for this chapter, we're going to talk about the urinary system and the physiology behind it. I want you guys to have a really good understanding of the anatomy of the kidneys. There will be a couple of questions just on basic anatomy of the urinary system and also the kidneys. The main kidney functions are to regulate all of the extracellular fluid environment in the body, including the volume of your blood plasma, which will affect your blood pressure, regulating all your wastes, your electrolytes, your pH, and they also secrete the hormone erythropoietin, which will stimulate red blood cell formation. So a basic introduction here, urine is made in the kidney nephrons, and that will drain into the renal pelvis and then down the ureter to the urinary bladder. It will pass from the bladder through the urethra to exit the body, and urine is transported using peristalsis, which is those smooth muscles kind of squeezing the urine along the tubes along. So here are the organs of the urinary system. Again, take a moment to review this from anatomy to have a good understanding of the organs of that. Here's the kidney structure. I'm going to let you guys work through this on your own, working through the cortex, the medulla, which is made up of your renal pyramids and columns. You should understand the basic pathway of how each pyramid drains. So each pyramid will consist of one collecting duct, which takes that urine and drains it into a minor calyx. Minor calyxes come together to form a major calyx, and then several major calyxes come together to form the renal pelvis. So here is the nephron structure, which is the filtration unit of the kidney, and blood will flow through the nephron as it filters out all the wastes that are excreted in the urine. Here's the renal pyramid in the renal medulla. The renal cortex is the layer on the exterior of the kidney, and each renal pyramid will drain into a kind of a minor calyx. Minor calyxes come together to form a major calyx. And this area right here is the renal pelvis, which will take the urine out through the ureter. Here are the basic kind of anatomy of the nephron. Here's the glomerular capsule where the glomerulus will be. The afferent and efferent arterioles will take blood in and out of the glomerular capsule where the blood is filtered. Then that filtrate will travel through the proximal convoluted tubule, up and down the nephron loop, the descending limb, and then the ascending limb, and then through the distal convoluted tubule, and then the filtrate will travel and collect in the collecting duct, and each collecting duct takes that filtrate through the renal pyramid. Here's a look of a radiograph of the urinary system, and this is something that can be done in a hospital setting where they can take a radiograph or see the urinary system to see if there's any blockages, kidney stones within the ureters. So we'll talk about kidney stones then. So this is called nephrolithiasis, or kidney stones are hard objects formed in the kidneys containing crystallized minerals or waste products. About 80% are calcium stones, but others can be magnesium ammonium phosphate or uric acid. The tendency to form kidney stones will be increased if a person is dehydrated. So just a reminder to drink lots of fluid. And large stones in the calyxes or pelvis may obstruct urine flow, and smaller stones, usually less than 5 millimeters, can actually pass into a ureter and can produce really intense pain. Treatment are medications that help to pass the kidney stones, or lithotripsy, which are shock waves used to shatter it, or even surgery if there are major blockages. Control of micturition. So micturition is the term for urinating. In terms of controlling that, you have detrusor muscles that line the wall of the urinary bladder. They're innervated by parasympathetic neurons. Sphincters will surround the urethra, the internal and external sphincter. And the external urethral sphincter is what is made up of skeletal muscle. So your detrusor muscles and your internal urethral sphincter are made up of smooth muscle, meaning this will be an involuntary process, the process of urinating. What we control is the external urethral sphincter, which is the voluntary skeletal muscle, so we can control when it exits the body. So you have stretch receptors in the bladder, which will send information to the S2, S4 regions of your spinal cord. Um, these neurons will normally inhibit the parasympathetic nerves, while somatic motor neurons will be stimulated. This will prevent involuntary emptying of the bladder. So this stretch reflex tells your brain basically that the bladder is full and ready to be emptied, but you have voluntary control over when the urine exits due to the external urethral sphincter. And this takes you through the stretch of the bladder will initiate in the voiding reflex. So the person will feel the need to urinate, but then control when to urinate with that external urethral sphincter. Urinary incontinence is uncontrolled urination due to a loss of bladder control and has many possible causes, sometimes due to stress, um, other due to increased abdominal pressure like sneezing, coughing, laughing. This happens in women when the pelvic floor no longer provides adequate support to the urethra due to childbirth or aging. You can get sling surgery in which a mesh can be inserted to help support the urethra. In men, urinary incontinence frequently occurs as a result of treatments for prostate cancer. An overactive bladder involves uncontrolled contractions of your detrusor muscle that can produce a great urge to urinate and leakage of urine. This urgency is a hallmark of a person with an overactive bladder who also will experience frequent urinations and other symptoms. Urinary incontinence can be diagnosed by urodynamic testing and other tests. So they'll measure the compliance of the bladder and how well it can be filled. And then the subject will be asked to say when the urge to urinate appears. So then we'll go through the nephron, the microscopic kidney structure of a nephron. So a nephron is the functional unit of the kidney. Each kidney has more than 1 million nephrons, and a nephron consists of the small tubules and associated blood vessels. Blood will be filtered, fluid enters the tubules, it will be modified, and then will leave the tubules as urine. So you should understand well, again, the anatomy structure here, especially the nephron, understanding where the glomerulus is, the proximal convoluted tubule, the nephron loop, and distal convoluted tubule. This takes you through the renal blood vessel anatomy. So how blood gets into and out of the kidneys follows this sequence. And I do want you guys to know this sequence. Blood will enter through the renal artery and then travel through the interlobar arteries, through the arcuate arteries, which are kind of on the border between the medulla and the cortex, into the interlobular arteries, and eventually into the afferent arterioles, which bring blood into the glomerulus where the filtration occurs. Leaving the glomerulus, we have efferent arterioles. They will travel into the peritubular capillaries, which will be capillaries that surround kind of the some of the filtration system where they can absorb more anything that needs to be absorbed back into the blood, into the interlobular veins, into the arcuate veins, to the interlobar veins, and then back out of the kidney through the renal vein. Here are the nephron tubules. So we have our glomerular capsule, which surrounds the glomerulus, and that makes up your renal corpuscle. Filtrate produced in the renal corpuscle will pass into first your proximal convoluted tubule. Next, fluid will pass into the descending and ascending limb of the loop of Henle. And after the loop of Henle, fluid will pass into the distal convoluted tubule. Finally, fluid will pass into the collecting duct, and the fluid is now urine and will drain into the minor calyx. So again, understanding well this system of how blood gets into the glomerulus where the filtration occurs. From here, everything filtered out of the blood will go into the proximal convoluted tubule, up and down the nephron loop into the distal convoluted tubule. The peritubular capillaries will surround the proximal convoluted tubule, so they'll kind of be ready to absorb anything else that gets secreted from the filtrate through the proximal convoluted tubule. And the peritubular capillaries will kind of continue down in what we call the Vasa recta, and they'll surround the loop of Henle to absorb or be ready to pick up anything else that gets secreted out of the filtrate to be picked up by the blood. There's two types of nephrons. The juxtamedullary are better at making concentrated urine. They're located kind of at the juxtaposition, they're located at the kind of connecting point between the cortex and the medulla, and the cortical nephrons are located more in the cortex region of the kidney. Polycystic kidney disease would be a congenital disorder in which the kidneys are enlarged due to fluid-filled cysts. So it's an autoimmune disease. An autosomal dominant gene will get passed on down. There's no cure presently available. There's only treatments for the complications of this disease. So glomerular filtration then. The capillaries of your glomerulus are fenestrated, which means there's large pores allowing water and solutes to leave, but not blood cells and plasma proteins. So what this means that in your glomerulus, there will be pores so that water and solutes can leave, but blood cells and plasma proteins will not. Fluid entering the glomerular capsule is called filtrate. Filtrates must pass through the capillary fenestrae, the glomerular basement membrane, and then a visceral layer of the glomerular capsule composed of cells called podocytes with extensions called pedicles. So this is a really cool look at the glomerular capillaries and capsule, just showing how these podocyte cell bodies and their podocytes kind of foot branches will wrap around the glomerulus, and there will be spaces between them to allow the filtrate to get through the glomerulus. So this is a look so let's take a look at this picture first. Here's the glomerulus, showing again how blood enters the glomerulus through the afferent arteriole and exits via the efferent arteriole. The filtrate will be filtered at very high pressure through this kind of layer of basement membrane and then the podocytes with their feet. These foot processes create slits called filtration slits, and that's what all the filtrate can get through as it's being filtered out of the blood into the glomerular space and then through the proximal convoluted tubule. So big picture, again, remember that your kidneys are working to filter all the blood in your body. This happens daily, where all the kidneys have to filter all the blood in your body, and all the filtrate, anything bad in your blood will get filtered through and get out the body as urine. And the red blood cells and proteins will remain in the blood. So this just shows the direction of the plasma, which will be what goes through this kind of wall of filtration. And here's the filtrate that's formed on the other side. So this is your filtration barrier, we call it. The slits in the pedicles our pores will be the major barrier for the filtration of plasma proteins. A defect here in these slits will cause proteinuria, which will be an increase of proteins in the urine. So normally proteins should not be in your urine, but if you find proteins in the urine, a defect is usually in the slits of the pedicles, which are allowing larger plasma proteins to get through. Fluid in the glomerular capsule will get there via hydrostatic pressure of the blood, colloid osmotic pressure, and a very permeable capillary. So you'll have an incredibly strong pressure force that produces a net filtration of about 10 millimeters of mercury that basically just forces all the filtrate out of the blood into the glomerular capsule space. So again, here's a look at the glomerulus. The afferent arteriole brings the blood in. You can see here the proteins in green are too large to get through those filtration slits. So again, if you find protein in your urine, that means there's a problem at these filtration slits. Normally protein is too large to be passed through the urine, but what does get through are these other solute particles, and you can see them, the smaller purple dots. So then what doesn't get filtered through exits out of the glomerulus as the efferent arteriole. And what does get through, these solute particles in purple, will travel down through the proximal convoluted tubule and through the rest of the urinary collection system. The glomerular filtration rate refers to the volume of filtrate produced by both kidneys each minute. And this is about 115 to 125 milliliters. It's about 45 gallons a day, which is an incredible amount of filtrate that your kidneys are filtering. Keep in mind that 45 gallons, you're not going to urinate 45 gallons a day. This is just what's going through the first step of the filtration process. So 45 gallons of filtrate will continue down the nephron system, and most of that will actually get reabsorbed back into the blood. Your total blood volume is filtered every 40 minutes, and most must be reabsorbed immediately further on down the system. So this is why people with kidney disease have to go through dialysis, because if their kidneys are not doing the normal filtration rate, they need help doing that in dialysis. Your afferent arterioles can be constricted or dilated, and that'll change your filtration rate, the amount of blood going through the glomerulus. And this is intrinsically or extrinsically regulated. Sympathetic nerve effects in the fight and flight response, there will be vasoconstriction of the afferent arterioles. So in a very stressful emergency situation, your sympathetic nervous system kicks into gear to try to divert blood away from your kidneys to your heart and muscles where it's needed. Urine formation will decrease to compensate for the drop in blood pressure. So again, sympathetic nerve effects will decrease the amount of blood getting to the kidneys. Renal autoregulation, the glomerular filtration rate will be maintained at a constant level, even when blood pressure fluctuates. Myogenic constriction, or when the smooth muscles and arterioles will sense an increase in blood pressure. The tubuloglomerular feedback has to do with cells in the ascending limb of the loop of Henle, called the macula densa. They will sense a rise in water and sodium, as occurs with increased blood pressure and filtration rate, and they'll send a chemical signal to also constrict the afferent arterioles. So this is some of the regulation of the glomerular filtration rate. Reabsorption of salt and water. Reabsorption refers to the return of filtered molecules back to the blood. So keep in mind that 180 liters, about 45 gallons of water is filtered per day, but only about 1 to 2 liters is excreted as urine, and that's because most of it is reabsorbed back into the bloodstream. This will increase when you're well hydrated and decrease when you're dehydrated. A minimum of 400 milliliters must be excreted to rid the body of wastes, and that's what we call obligatory water loss. So you're going to urinate out at least 400 milliliters a day. About 85% of reabsorption occurs in the proximal tubules and the descending loop of Henle. This portion is unregulated. So again, remember, about 180 liters of that water will be filtered, but most of it will be reabsorbed right in the proximal convoluted tubule and also the descending loop of Henle. That's all that I really want you to know. Sodium will be actively transported out of the filtrate in the peritubular blood to set up a concentration gradient to drive osmosis, meaning once sodium is filtered, water is going to follow that process. Active transport also occurs to try to get sodium out of the filtrate. So you should know that a little bit, but that's all you need to know. Passive transport also occurs. Water will follow sodium and chloride into the tubular cells and into the interstitial space. But again, this is all talking about reabsorption, getting water and sodium and chloride back into the blood. So here we go again. Here's reabsorption. Water will follow salt by osmosis. Sodium will be actively transported and chloride will be passively transported. The significance of proximal tubule reabsorption, 65% of salt and water is reabsorbed, but that is still too much filtrate. So an additional 20% of water will be reabsorbed through the descending loop of Henle. Water cannot be actively pumped out of the tubes, and it will not cross if it's isotonic. So the structure of the loop of Henle allows for the concentration gradient to be set up for the osmosis of water. The ascending portion will set up this concentration gradient. The ascending loop, salt will be actively pumped in the interstitial fluid. So we're trying to create a concentration gradient that water will want to flow into by osmosis so that more of the water is reabsorbed from the filtrate. This kind of takes you through the transport of ions into the ascending limb of the loop of Henle. You don't need to know the details of this. Again, I just want you to know that there's a concentration gradient that gets established by the ascending loop, and that allows water to passively flow through osmosis to be reabsorbed. And I'm going to skip over some of these slides. You can read on your own. But again, I want you to know here is the descending loop where water will be passively reabsorbed back into capillaries, but it's able to do so because of the concentration gradient set up in the ascending limb. And I'm going to skip through the countercurrent multiplier system because it describes the concentration gradient setup. The Vasa recta or Vasa recta, I do want you to know these are specialized blood vessels that are around the loop of Henle, which also have what we call a descending and an ascending portion. They help create this countercurrent system because they'll take in salts in the descending region but lose them in the ascending region. So this Vasa recta, this is just the capillaries that will reabsorb the filtrate and what's in the filtrate and what's in the blood to reabsorb some of that filtrate. So this is the Vasa recta. The effects of urea. Urea is a waste product of protein metabolism, and it will also contribute to the countercurrent system to help set up these solute concentration gradients. So this is where urea comes into play. You can see here where water is being absorbed back into the interstitial fluid and the Vasa recta. You can see here where sodium and water will be absorbed and reabsorbed back into the system. So urea just helps to establish some of those concentration gradients. This takes you through maybe just kind of a good summary of the transport properties of different segments of the renal tubules and the collecting ducts in the passive transport of water and urea. Knowing kind of probably this chart, and that's about it. It is kind of confusing where everything gets reabsorbed. But knowing this chart takes you through kind of a good summary of where everything gets reabsorbed. Again, I won't ask you too many details on this, just understanding that your glomerulus filters out a ton of filtrate a day, but most of it gets reabsorbed right away back into the peritubular capillaries and the Vasa recta. So this takes you through kind of the differences. These numbers are where things are getting absorbed and showing the Vasa recta and where they'll be right next to the tubular system ready to reabsorb ions and water back into the blood. Collecting duct and ADH, the last stop in your information is the collecting duct. It's impermeable to sodium chloride at this time, which is the salt, but it is permeable to water. It's also influenced by the hypertonicity of the interstitial space. Water will leave via osmosis if it's able to. The permeability to water depends on the number of aquaporin channels in the cells of the collecting duct, and the availability of aquaporins is determined by antidiuretic hormone. So antidiuretic hormone basically will be produced by the neurons in your hypothalamus, but stored in the pituitary gland, and it will be released. It's stimulated by an increase in blood osmolarity. So antidiuretic hormone, basically, a negative feedback, a stimulus will be low water intake or dehydration. So that'll increase the plasma osmolarity. Your antidiuretic hormone will be released to act on your kidneys to increase water reabsorption, where less water is excreted in the urine, so you'll get more concentrated urine. So antidiuretic hormone will kind of increase blood fluid volume to try to increase more water, and you'll decrease less water you'll decrease the excretion of water back into the urine. So this takes you through antidiuretic hormone. The effects on blood, antidiuretic hormone will increase water retention. So you can see here, if blood volume increases, antidiuretic hormone will decrease. If blood volume decreases, antidiuretic hormone will be increased to try to increase blood volume. Diabetes insipidus is characterized by polyuria, which is a large urine volume, thirst, and polydipsia, which is drinking lots of fluid. The urine is extremely dilute. There are two major types of diabetes insipidus. They all have to do with an inadequate or inability of the kidneys to respond to ADH or inadequate secretion of ADH. So that's diabetes insipidus, having to do with that antidiuretic hormone. Either your kidneys are not responding to it or you're not secreting adequate ADH. So you'll form extremely dilute urine. More commonly, it is acquired as a response to drug therapy or other causes. People with central diabetes insipidus can take desmopressin when needed, and those with nephronic diabetes insipidus must drink a lot of water to prevent dehydration. Renal plasma clearance. We'll kind of run through this. We'll just talk a little bit, kind of a summary of it. Your kidneys must also remove excess ions and wastes from the blood. Sometimes this is called renal clearance. Filtration in the glomerular capsule begins this process, and reabsorption returns substances to the blood, and secretion finishes the process when substances are moved from the peritubular capillaries into the tubules. So just acting as this renal clearance, what your kidneys can clear as urine. This takes us through the excretion rate. Again, excretion rate, secretion is the reverse of reabsorption. So we talked about reabsorption, things being reabsorbed back into the blood. Secretion is actually putting ions back into the waste, the filtrate, to be excreted out as urine. Secretion of drugs is important. So this can be very fast. It may interfere with the action of therapeutic drugs. So drugs can be secreted out through the urine. I'm going to kind of pass over some of this, but this is just renal clearance of inulin, renal plasma clearance calculation. You won't need to know this, so I'm going to pass over this. Estimated the glomerular filtration rate with creatinine. Creatinine is produced in muscles from creatine and released into the blood plasma, where its concentration is used to help assess kidney function. It can change based on a person's age, sex, weight, and how it can be calculated with that estimated glomerular filtration rate as well. So this just takes us through what all I want you guys to understand is understanding renal plasma clearance and understanding these terms, what filtration means, reabsorption means, and secretion means. And you don't need to know renal handling of these different molecules in the blood plasma. So I'm going to kind of go over these other kind of how the other molecules are cleared by the kidneys. Glucose is one that's easily filtered out into the glomerular capsule, and it's usually completely reabsorbed in the proximal tubule. So that is glucose. So reabsorption of glucose, renal control of electrocyte and acid-base balance. Your kidneys will match electrolyte excretion to ingestion. So it'll control your sodium levels. It's important for blood pressure and blood volume. The control of potassium levels is important in healthy skeletal and cardiac muscle activity. And aldosterone will play a big role in sodium-potassium balance. About 90% of filtered sodium and potassium is reabsorbed early in the nephron. And we're going to talk a little bit about aldosterone here. An aldosterone-dependent response, an increase in blood potassium will trigger the adrenal cortex to release aldosterone, and this will increase potassium secretion to try to rid the body of more potassium. So potassium is reabsorbed and as well as secreted, and the amount of potassium in the blood or the urine will be controlled by aldosterone. All right. The juxtaglomerular apparatus is located where the afferent arteriole comes into contact with the distal tubule. So this is the juxtaglomerular apparatus. It consists of these macular densa and granular cells. A decrease in plasma sodium will result in a fall in blood volume, and your juxtaglomerular apparatus can sense this, and the granular cells will begin to secrete renin. So, with any fall in blood volume or blood pressure, the juxtaglomerular apparatus cells can um, figure out can sense this, and they will start to secrete renin. Renin will convert angiotensinogen to angiotensin 1, and angiotensin converting enzyme will convert this to angiotensin 2. This will stimulate your adrenal cortex to make aldosterone, which will promote the reabsorption of sodium and promote the secretion of potassium. What this is important for is this will directly increase blood volume and raise your blood pressure. So if you have a situation, if you're a trauma situation and you're losing a lot of blood, either internally or externally, your kidneys will secrete renin because this drop in blood volume will be sensed by these juxtaglomerular apparatus cells. The secretion of renin through several steps will directly increase blood volume and raise blood pressure. So this kind of goes through the regulation of renin stimulation, but all I want you to know is that if there is some sort of trauma situation, your blood pressure is dropped, renin will be secreted to increase blood pressure and increase blood volume. The macula densa, these are where those cells will be that are able to sense any sort of kind of change in concentration of sodium or water. Atrial natriuretic peptide is another important hormone. It increases in blood volume, also increase the release of this. It's a hormone from the atria of the heart. When the atrial walls are stretched, it'll be released, and it will actually stimulate your kidneys to excrete more salt and therefore more water. So this is often abbreviated ANP hormone from the heart, and it will decrease blood volume and blood pressure. In addition to ANP, scientists have discovered this hormones released by the heart ventricles called B-type natriuretic peptide, and this will be secreted in response to increased volume and pressure within the ventricles. And it will act like ANP to promote diuresis, which is more frequent urination. So regulation of renin and aldosterone secretion. Again, renin and aldosterone are really important in increasing blood volume by increasing sodium and water reabsorption in the kidneys. A relationship between sodium, potassium, and hydrogen ions. I'm going to pass over this for now. Acid-base regulation. Your kidneys maintain blood pH by reabsorbing bicarbonate ion and secreting hydrogen. So urine is usually acidic, and it also kind of the bicarbonate cannot pass the inner tubule. This kind of takes us through carbon dioxide a little bit and how carbon dioxide plays a role in acid-base regulation. All I want you to understand is that your kidneys play a role in the acidification of urine and acid-base pH levels of the blood. There's pH disturbances, so kidneys can help compensate for respiratory problems. Alkalosis is where you have a more basic blood pH, and acidosis is a more acidic blood pH. All right, urinary buffers. Nephrons cannot produce urine with a pH below 4.5, so urine must be buffered, and there's different phosphates and ammonia that are used to buffer the urine. Some clinical applications: use of diuretics are used clinically to control blood pressure and relieve edema, fluid accumulation, or swelling. Diuretics will increase urine volume, decreasing blood volume and interstitial fluid volume. Many types will act on different portions of the nephron. So different diuretics, whether it's Lasix, can work on the loop diuretics or other parts of the nephron tubular system. You don't need to know the different diuretics, but there's different classes, and they'll work just on different sites of the urinary system to try to either inhibit reabsorption or inhibit sodium transport to try to basically make you pee more frequently, and that's what a diuretic is. Renal function tests. These are function tests to try to look for any abnormalities in the urine, you're usually looking for an overexcretion of proteins. This could usually signify some sort of nephrotic system, a problem in the glomerular filtration if there's too much kidney. Acute renal failure, the ability of kidneys to regulate blood volume, pH, and solute concentration will deteriorate in a matter of hours and days in acute renal failure. And this can be due to decreased blood flow through the kidneys due to atherosclerosis of your renal tubules, inflammation of your renal tubules, or use of certain drugs such as NSAIDs. Glomerular nephritis is inflammation of the glomerulus. This is an autoimmune disease with antibodies produced in response to streptococcus infection. Many glomeruli can be destroyed and others are more permeable to proteins. So loss of proteins from the blood can reduce blood osmotic pressure and could lead to edema as well. Renal insufficiency is any reduction in renal activity. It can be caused by glomerular nephritis, diabetes, atherosclerosis, or blockage by kidney stones. And it can lead to high blood pressure, high blood potassium and hydrogen, and uremia, which is urea in the blood. Patients with uremia are placed on dialysis machines to clear the blood of those solutes. Renal insufficiency is any reduction in renal activity. It can be caused by any sort of blockage, atherosclerosis, diabetes, kidney stones. It can also lead to the urea in the blood, and they are also usually placed on a dialysis machine. So what is dialysis? This is an artificial kidney. Hemodialysis is cleansing the blood of wastes as it passes through dialysis fluid. CAPD is a continuous ambulatory peritoneal dialysis where dialysis fluid is introduced to the abdominal cavity where wastes can pass out of the abdominal blood vessels and fluid is then pumped out of the abdominal cavity. So that is dialysis. You see dialysis clinics everywhere. Usually the elderly are taken there when their kidneys fail. So again, take good care of your bodies because you want your kidneys to be functioning well into your old age as well. Thanks for listening, guys, and I'll try to get the other PowerPoints uploaded much more quickly than this one.